And okay, go ahead.
Okay, I'm just trying to put my there. Okay, and I'm just going to move this a little bit over here. Okay, so today, thank you again very much. And today, really, I just have one goal, and that's to sort of share with you how Nurse on Board can support you and your family through, with different health matters through a variety of situations. And all our patients have very unique needs and are coming from different places. So it's all very, very different. So for a moment, when you think about you got up today, you maybe took a shower or shaved or put your makeup on, got downstairs, had your breakfast, and you just sort of did that without thinking, but all of a sudden something happens and your world changes dramatically. So if you think about, what if you had a sudden health crisis and you needed to see multiple specialists, make lots of decisions, and you weren't really sure what to do. All of a sudden one of your parents become ill and they might actually be the caregiver of another parent, and you need to have resources in place and again not sure where to turn to, and you're still working, so it's hard to manage multiple situations sometimes, and it's very stressful for the family. Imagine living alone with a chronic health problem, no relatives close by, and no one to turn to in order to get help. So these are situations that we've been involved in reality with some of our clients. And for a moment, if you think all of a sudden you need to get equipment in your home, but you're not sure, do I go to Shoppers Drug Mart and buy a wheelchair, or what really will my needs be down the road? You may have some medications that you're currently just taking out of pill bottles and administering yourself, but now, there's many more and it becomes a bit confusing. Gee, did I take my meds today or not? So we can help you with pharmacies in that area. There's maybe you're not able to sort of get into the bathtub anymore, but how can we make that happen? What do we need to do in order to support you? And definitely stairs. Right now, most of our houses have a lot of stairs in them, and all of a sudden you're on a walker. And so you can't get up to your bedroom. And what does that look like? And is there some way we can help to mitigate, some of these circumstances? So, you know, um, having, these are things that we often help with for sure. So really, who is Nurse on Board? So it was started in 2014 by Susan Hager, who was a nurse, a very experienced nurse with over 25 years, actually in the Heart Institute, who saw gaps in healthcare, both from a professional and personal nature, and wanted to support people on their journey. So she created a company of registered nurses with extensive clinical background, with years of experience, including specialization. And as Sudash said, my background's been neuroscience my whole career. And so we're a group of nurses actually in independent practice. So not all nurses work in hospitals like the TV would lead you to believe, Some of us are out there in the community and working, and we actually have our own practice. And so we are contracted to Nurse on Board, and so we are care managers. Excuse me. And we're dedicated to providing the right care at the right time in the right place. And I'd like to excuse myself with all these slides and a lot of words on them, but I knew this might be recorded and maybe accessed. So for those of you that aren't here today, at least the slides will help provide you with some of the information. So Nurse on Board truly is unique in Ottawa and in Ontario, and we really haven't found any other company in Canada like this. I'm sure there's very different similar companies, but really for us sort of taking on the gestalt of the health problem and all the other things that come under that, we sort of haven't come across that. We have 8 sites in Ontario, so there are nurses in those sites that work with nurse on board and are able to provide support to the family. And all of our care managers, we consider the full spectrum of both physical and mental health needs, both from a diagnosis perspective, through acute care, chronic care, and the end of life wishes. And I'm going to share with you a bit of stories today, obviously keeping things confidential, but some of the situations that we actually have dealt with. We currently have served over 300 families in the Ottawa area, where 30% of our persons have remained with us as their care provider and support for greater than 5 years. And I've had one gentleman that I started with, excuse me, he had a little bit of dementia, but he was fine. He, excuse me, he had good mobility and was able to move around, but he did have a progressive neurological illness and he became more demented. So, I had to move him from where he was to a more supportive environment and see him right through to actually death. And we had many conversations along those years about what he wanted to be like at the end of life and where he wanted to be. So I was able to take him back to the retirement home, and we were able to deliver palliative services at the retirement home. As he lost his ability to speech and work with words, we carved out on a book about his life, and we could go back and help him cognitively maintain as much cognition as he could. And also, I was able to understand his language because I had been with him for so long. And although he might be using the wrong word, I could tell by the context really what he was trying to say. So it was an amazing experience for myself. So sometimes we get involved with patients really at the acute onset of an illness, and we've actually had someone call us from a hospital bed on a Saturday morning. They'd had surgery, things had gone not well, and they just didn't know what to do, and so they called us. So sometimes it might be acute illness, or maybe we're with the person and then something untoward happens and we're now at the hospital. So in the hospital setting, we assess the patient in the hospital or the rehabilitation. We meet with the hospital team to find out more about their care and sort of, upcoming tests and treatment options. And the important thing is we keep the family abreast of what's going on. And so they know that there's someone there with their loved one by their side that can sort of report back. We certainly don't replace what the team are saying, but we help the families understand the situation and so put it in a context. So with my background, if the person's had a stroke, well, then I can talk about the types of stroke. What does that really mean? Why is the person, experiencing these kinds of symptoms? And we can also help families work for maybe different options or other parameters. We certainly work with the team to support a really good transition home, and that there's no gaps in the system. And this is where, equipment might be coming in. We might be looking at the care plan in hospital and implementing the care plan in a retirement home and making sure there's a smooth transition. In one place, I had one gentleman that he was waiting for a bed to go somewhere else to be in a program, but he was spending all this time with not doing anything, and we could mimic his needs in the retirement home. So it was better to get him back there, get him up, get him dressed, cognitively better, and we were able to fill the gap of his needs at the retirement home. So we work with the patient and the family then to follow up also on discharge recommendations. So let's say they've come from the geriatric assessment unit and there are a number of things that the team recommend. Well, then we would want to implement that actually in the home or in the retirement center or wherever this person is, because really your address should not dictate really what you need, So how can we help? Well, again, assess and address other health concerns in the home or wherever you are. We also coordinate both public and private services. So we work with what used to be called the Lynn. I think it's called the Home and Community Care Support Services now. And so we're used to meeting with the managers, finding out, what they can offer our clients, be very clear if that contract has gone out to a third party, that third party is delivering what is supposed to be delivered. And we also, if the patient wants, then we can contact other private services, like maybe what we find is if you need a PSW, the Lynn might provide, an hour here, an hour there, but maybe you actually need much more. So we know who's out there, who are good companies that provide reputable services. So we can help in those ways. And again, we support, any conversations that need to happen. And for me, having worked with an interprofessional team my whole career, physio, OT, speech, I can see situations where maybe they need a neurophysio in there because maybe this person has a chance to really improve neurologically after the stroke. And so maybe we can have somebody with very qualified team member come in and help them. I had a lady who her husband, after rehab, things had fallen through the cracks at home. He ended up putting her in a retirement home. And after 2 years, he said, "That's it, I'm done. I want her home." And so I helped facilitate her coming home, put the services in place. And when I really looked at her files and CT reports and whatnot, I thought, I don't really understand why this lady can't walk. And so we actually got her walking after 2 years of not walking. And that was with the help of a neurophysio. And it didn't come easy, but we were able to capitalize on things that truly we could capitalize on. We also look at evaluating medications, options in terms of, is it delivery pack? Who's pouring the meds? What are the ramifications around special delivery? PSWs cannot really administer medications in the home unless they've been specifically trained, and that authority has been given to them. So we're very careful on those parameters in terms of who's giving the medications in the home. And we're there to support the patient if in case there's a medication error. We develop and implement a very personalized goal of care. What do you want to work on and getting better? What are the top 3 things you'd like us to work on? And then we try and focus on those aspects. We supervise complex care and specialized disease management. So this person might have a lot of things going on, but yet really truly want to be home, and we can try and support all the things that need to be in place. We also investigate other treatment options and also opportunities for a second opinion, because sometimes patients just want to know, have I really exhausted everything that I can, to help with me getting better. We also direct and oversee and navigate healthcare for persons and the family with the power of attorney. So, we help them to navigate the healthcare system, knowing who to call. And we work with, obviously, the patient, but we also work with the family and or power of attorney, whatever that may be. We also accompany them to medical appointments. And this is where I think it's really crucial. The family doctor, the physicians have a kind of a set amount of time, and you want to really maximize that time with them. So we figure out, well, what do we really need to talk about? Because sometimes I've seen family members come with like 15 different topics, and it sort of gets lost in the translation of trying to really help them, and we can only focus on a few. So, what top issues do you really want to address? And what do we need to do to collect the information for the physician? So when we get there, we can speak to the problem, how it's changed, what works, and what doesn't work. So if you say, well, I have a headache, okay, gee, a headache could be caused by a million things, but if you narrow it down and put it into context, then that's really helpful for the physician to sort of start thinking about, could be this, could be that, whatever, and what appropriate tests need to be done. We help translate medical terminology and provide health education. And so Dash and I know, working in hospitals with maybe young residents, and they'll use very medical jargon, and it's very hard. The family will nod, but then they really not sure what that really means. So we try and break all of those pieces down to be really clear how to help the family. And there might be other sources that we can help, like booklets or resources to help provide more information. And definitely, and I'll talk a little bit about this later, but we do, with the family's permission, and we have them sign what we call, it's called the Privacy Health Information Act. And what that does is that it gives us, you give the legal authority for whomever to be able to speak to us. It's called a PIPA. And we before we can have any conversations with anybody, first of all, we always ask you, is it okay if I speak to your family doctor? Is it okay if I speak to, you've got a cardiology appointment? Is it okay if I'm there, or I'm on the phone with you, or, in person? And we always get permission, and I always write the doctor or whomever I'm going to be working with a letter of introduction, so they know who I am, they know how I'm positioned. I'm not there to make any decisions, but I'm there to provide a bridge between the healthcare, provider or the physician or whomever, and myself, and how we can help you on your journey. And we also can guide decisions about integrative medicine, which are other avenues. There may be not a pill form or things like that, but there may be other integrative medicine areas that can actually help the person. And that includes cannabis. And several of our nurses have taken a lot of courses on cannabis, and they're cannabis competent, shall I say. And we work with another company to be seen, to get an extensive history done, and to be able to facilitate a prescription, and how everything might be titrated. So I'm not an expert in that, but certainly other nurses with Nurse on Board are, and some patients, they really find that's very helpful. The other thing that we talk about is often difficult decisions. And with the journey, sometimes it's not clear. And I actually had a neighbor of mine reach out to me, about 2 years ago. And, both parents were, getting on in their years, and the question is, should they stay at home, or should they move to retirement? Should they move to long-term care? These are very deep, deep discussions, and there's a lot of things, a lot of thinking. What's best now and down the road? Where do you want to be? A lot of decisions have to be made around here, but you have to sort of know what you need to think about in order to do that. And I've gone with clients with another company, and we've looked at retirement homes, and that might be what they might be looking at, the granite counter, the fireplace, the lovely dining room, which is lovely. I'm looking at how many PSWs are here on day shift, on night shift. What is the proportion of the number of people that the PSWs need to look at? So one PSW per 8 patients, 10 patients, what does that look like? And where, who's the physician? Do they come regularly? Do they make rounds? How can they be reached? Is the director of care easily accessible? can you go in and have conversations with them? So there's a lot of other things behind the scene that I look at to make sure that, yeah, I think this place is the right place, if you so choose. So we just try and provide that more global perspective when people are thinking about, maybe next steps or staying in the home. And we know in Ontario, and certainly as the new Ontario health systems roll out, they are really encouraging people to stay in the home, which is absolutely lovely. And hopefully there'll be more dollars put into supporting there. And as they say, also lots to consider and what works best in the long run. For a variety of reasons, both my brothers and myself, we decided with my mom, she wanted to go to a retirement home. And we knew that with her diagnosis of dementia that, things would unfortunately get worse. And they did have a memory care floor there, which we were very pleased. So when my mother had to move to it, I mean, it was an easy move within the building. The staff still knew her. We had set up a trusted relationship of care with the retirement home, and it was helpful versus trying to take her out and move her to a new place and all that kind of stuff. So these are deep things that you need to think about, when you're taking your journey on these thoughts. The other thing is, what the patient wants, what the family want, and also, how can we provide support? And we're hoping that, most patients have some trusted family member that maybe is their spokesperson. Maybe they have been identified as the power of attorney to help them. And we work closely with the family and or the power of attorney to make sure that, that whatever is wished for, that we can help provide the best support for them. One area that we also have discussions in is called advanced care planning. And interestingly enough, I go to neuro rounds every Friday morning from 8 to 9. And this morning, the topic was advanced care planning and prognostication in patients with neurological disease. So, and I'm finding out that the Ottawa Hospital has a serious illness counseling or conversation program. So that's interesting to know. So I think all of us as healthcare professionals are getting more comfortable in working with families to have those very tough discussions about advanced care planning, what the future might look like. And I can put on these slides. There's an organization called Speak Up Ontario, which has an excellent guidebook for families to work through. And there's also advanced care planning in Canada. And there are books that if you haven't had those discussions with your loved ones, then you can sit down, you can work through things, and then have a discussion with your family. This is really what I'd like in my life, because as you know, there's a power of attorney for finances and a power of attorney for health. And so you need to have those discussions so your wishes will be acknowledged and abided by such time when you can't make decisions at that point, and it might be an interim basis. So it's really important for them to know what your wishes are, and also, do they have the documents? So if something untoward happened, do your POAs have those legal documents that you might have to show either a hospital or somewhere that say, yes, I am the power of attorney for this client. I had a situation where I had a client fire his power of attorney, and in his document it went to the next person, but he never knew that he was actually named in a legal document. And so he was informed of it and he was surprised. I mean, he was pleased, but he also had never had those conversations with his friend. And then there was disgruntled between the POAs and whatnot, and neither one of them wanted to take the case on. And we had to plead to say, please, 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 given this individual and his health status, we want to know that someone's actually legally in charge here. And so we were able to help the powers of attorney, see the light and help us to be very clear, how we could support the client. We've also had discussions with do not resuscitation and what that means. And Nurse on Board has a document that we walk the family through what it means, what it doesn't mean, what if this, what if that. And so it might be something that some patients are very clear about and some others not. And it's like, well, I never really thought about that before. And once you're at a stage where you have more caregivers coming in, be it in hospital, be it in your home, whatever, we do have to address the issue of what if somebody found you, do we actually start CPR or not? And that also includes the ambulance. So if someone calls 911 and the ambulance shows up without that documentation in the home, they will do CPR. And that may not be actually the person's wishes. And so, at certain times we do need to have those discussions. There's a proper form that comes from the Ministry of Long-Term Health in Ontario, and nurses can sign that. So, I have signed those forms with my clients after some having a very extensive discussion. And of course, we also, if we have a meeting coming up with the family doctor, that's one of the areas that we would discuss. So the family doctor is certainly aware that this is what they want and they can facilitate with the form. Or if it's something that we've signed off. I had a client this year that was very clear. She had a terminal illness and she was absolutely clear she did not want to be resuscitated. So it was a form that I could fill in, leave in the family home so it would be seen by the healthcare providers and the ambulance crew, and also obviously to inform the family doctor that this is where we're at. So we kind of see them from beginning to end. One of the things that we do is simplify and support these end-of-life decisions, but also palliative care choices. And so if someone is palliative, where do they want to be? Do they want to maybe be in hospital? Have they had those discussions with their family? I'd like to be at home. What does that mean for everybody in the family, for the children? And again, there's lots of thinking through that. And there's many options, including, as they say, wanting to be at home. And in fact, the Champlain Hospice and Palliative Care Program have a very extensive program, and they have everything organized. And, they will come out and see you in your home, and based on assessments, they will, come more often, sort of as necessary. And we're there as well often to help provide care if necessary, but work with these services are often contracted out to a company, let's say Bayshore Health Unit or St. Elizabeth or CBI, and we work with them as well to make sure that are there things from our side we can work with, hospice services are kind of based on your postal code. And so there's a variety of services in Ottawa and the region, and sometimes it's sorting out who's who and how can I go to hospice if that's the plan and all that. So it's actually, there's a fair amount of detail in all of that. And again, some of our we have kind of a palliative care arm in with Nurse on Board that's developing, and because we're recognizing the need, and people are starting to seek us out. The other thing that we can talk about is something called medical assistance in death. And based on cultural, religion, values, beliefs, for some people this is never going to be a discussion. For some people it might be a discussion, and they want information about it and what that really means. And I several of us have attended many sessions both with the Ottawa Hospital and the Dying with Dignity, to sort of look at the eligibility criteria, and what does I think it's Bill C-14 is saying in the latest legal mandate as of March, and we can help with those discussions. There are some forms to fill in, and I actually it was requested by one of my clients this a few months ago that this is what she wanted. And so I went through the process with her, and we need to get someone to witness her signature. She was very clear about it. There was no mistaking, but for the family member, they were distraught. I mean, this was a family that talked about this all the time, but the reality was now, of course, the parent was going to die, in the next 2-3 months, and now they actually wanted to die sooner. And this was very, very difficult on the family member, who was a son, and he needed support through all of this. And again, it was very tough. So I was able to, we get the form signed, send it to either the Ottawa Hospital or the Queensway Carleton, and then, there's a whole process involved in all of that. And then also, if they want work with the family in the grieving process, and what services are available for them to help them through their grief, which of course has no limit, right? So through all of this, then obviously we need to work with a number of people, and collaboration is important. And, most, even in the public sectors, most people get what we do. Sometimes we run across a few individuals that, because these services are paid by the client, then they kind of feel, well, we're not legit. And so, we need to be our College of Nurses, we need police reports, we need all the things that we need to do for working in an a hospital, whatever. We're a healthcare organization, and we're just sort of a member of the team. And so, as I said, we work with the home and community care folks quite extensively. We also work with a retirement home and long-term care. So if our client is in or going to one of those, then we work with them as well and their staff. We've had to take patients to the emergency department several times. And again, when we show up, we know the patient, we're articulate, we can talk the talk, we understand what's being said medically and be able to help the patient understand that, and the family. And we come with documents and a history. Then that's really helpful for the emergency team to expedite services. We work closely with the family doctors and other specialists, and I picked up some clients over a year ago, and I've been the only one allowed in their house because of COVID since for about the last 18 months. And they are not going out to see the family doctor, and so the family doctor came on the phone, and I was in the home, and we were able to go through, spend time going through all of these situations with both the husband and the wife. I got a lot of good details. And then from then on, I'm monitoring things that the physician would like me to monitor in the home. And then we provide reports then to the physicians or ask them about certain things. So we fax a letter to them and they get back to us, and it might be something like, gee, maybe I think the person has a urine infection and I need a lab requisition. And so we can have that discussion with the family doctor. They can fax me a lab requisition. We can go get the sample and get on, and hopefully the patient doesn't have to go to the emergency department. We certainly don't ever want to take away the wonderful assessments that the family physicians do. And so there may be times when we need to come in and be assessed and whatnot. So, we're just there to support the team in any which way. We definitely work with pharmacies to ensure medication reconciliation, work with changes that have come. Maybe medications have altered, so we work with, okay, well, maybe you can take this blister pack and back, and we'll exchange it for this. And so we try and make sure that the medications are up to date, and work with the pharmacies. A couple of my clients hadn't had their Prolia shot, way overdue. So I was able to, go to the pharmacy, pick up the drug, and go to the home and deliver the medication. We arrange tests, and including home lab work, so Dynacare, Lifeline, they will come in and do blood work in the home. Some of them can do ECGs, so we make the arrangements with that as well, and work with the payment option for the family. We have foot care. We work with a good foot care company, and they come in and provide care in the home if the person does not want to go out or can't go out. And I've also coordinated care across many different healthcare organizations, including cities and region. And I had a gentleman that was in Kingston a few years ago, this case, and I traveled to Kingston for the 2 years. He basically was in ICU, and they just sort of said to the family, he's never going to get better, that's it. And we weren't really sure that might be the case. So he actually recovered. I got him home successfully in 9 months. But he had a long healthcare journey, and I saw him through 8 different healthcare organizations. So it was keeping the story straight. And, when you think of one person that's in your toolkit of life, I do believe there's a very strong role for nursing, where we can facilitate many things in health. And so, you have your family doctor. You don't see them every day, but when you need to see them, you see them. So it's like us. We're there on your journey. If things are in place, then you may not need to see us that often, and we see you when we need you. But so it varies extensively. We also work with insurance companies. Sun Life is pretty good so far, to try and get money back. And so there's a nursing questionnaire form that we can explain, and fill in, and with the physician, and discuss our services. And often then the physician still needs to sign and maybe fill out the form. Sometimes we help them for sure, and often then you can recoup insurance monies that really are due to come back to you. 2 of our members have spoken to about 65 insurance companies, and so we're really looking to be clear what the needs are, and it's not just a black and white policy, but in fact, expanding even what the insurance companies can give. So we try and work with that. And we also work with the family doctor regarding the disability tax credit. And sometimes people are disabled, and that can be put forth for the Canada revenue taxation. And I had the situation where my gentleman was in a retirement home, and we needed the family doctor who was working with the home to fill in the papers. But this gentleman had been on a 2-year journey, and in fact his the information was way back actually 3 years. And so it was picking up the story when the disability started, following up with physician notes from the hospital, from the rehabilitation, putting a dossier together, and basically filling in a lot of the details for this new physician that really didn't know the patient at all. But, with that help, we were able to provide a very informative disability tax credit information to CRA, and the family were able to get, substantial money back. And of course, we also work with the powers of attorney, which may be near and far. And sometimes we've had where the power of attorney was in a different country, and their loved one was in a retirement home, and we were kind of like the contact on the ground, where we could pop in, see how things were going, make sure that whatever needed to happen was happening at that level. We've had situations where the person lives alone. They're falling through the cracks, and they've been referred to us maybe from a lawyer or someone who knew them. We were able to contact the family, have discussions about what we thought the options were, and as this person becomes more and more compromised and unable to handle their finances and whatnot, then we might have a family member that's again in another province or thousands of miles away, and we work with, maybe they've decided to set up a trust account and all the billing goes through that. And so the person is well cared for, they don't have to make decisions, but we have all the right things in place to make things happen successfully. So we haven't found really another company that does this, and that's sort of it. It's that global perspective, really care managing, and sort of that's what we do. So I think in just this last few seconds, just want to be aware of the time. So we have a 30-minute free phone call session where you'd call nurse, you'd send contact nurse on board, and Susan would take the call, and they share what the issue is, and maybe how we could help, or maybe we can't help, or maybe we can suggest something else. So they may not end up coming to us, but we may say, oh gosh, maybe, I would suggest trying here. Susan will reach out to the nurse then that's available and maybe has the skill set given, what the person's looking for. They make sort of a virtual introduction by email, and then the care manager and the person set up a time to gather information about the situation and how they can help specifically in that case. And the person may want some time to think about it, given, okay, well, this is what the costs are, and or they might say, no, this is exactly what I need. Excuse me. So once they agree that they're interested, then we establish an initial visit document in our electronic health record, and that sets up with your email, and that sets up then where we can send further documents via a secure portal. So we'll send up, some FAQs about the services. We'll include the client agreement and the Privacy Health Information Protection Act document that needs to be signed in order for us to legally have discussions. We'll do an initial home visit called a health and social intake information. And again, we can send that ahead to the family and they can fill it out. And then we sort of establish a plan of care after we've been there and seen the person. We have a very secure electronic health record where we document, and we can send documents out 2 ways. I can send faxes to the family doctor, the labs, and right now I'm working with the Ministry of Transport to help get my client's driver's license back. And we can also capture information and trend it. So for like blood pressure, weights, things like that. We also have the ability for PSWs in the home. We give them a link and they can actually do a little bit of charting, and it goes and it populates actually right into our health record. Um, so in the closing statement, I just want to say this was a document. There was in 2014, the Ontario government went on to find out how they could improve healthcare in Ontario. And in 2015, there was an expert panel of a variety of people, including nurses, and they went out and they talked to thousands and thousands of patients in Ontario and clients in the home and say, what is it that you'd like? And this is what they said. They want the client is the total family. So they want to be treated as the family, not just one person. Families want to be actively involved in the planning of their care. They need flexibility in tailoring the plan to meet the unique needs and the evolving situation. They want to know that they're doing the right things. So if you're trying to get someone out of, to transfer them after a stroke and that, we want to know that they're doing the right thing. So absolutely, we're there to help them. They want a 24-hour helpline, and someone to talk to. Well, we don't run a 24-hour service. However, if you need to call on a weekend or, something's going to happen, most of us are very happy to take the call. And I've gotten calls like, 11 o'clock at night, my client's in the emerge department. The wife didn't go, the POA son is in the US on the side of the road. And I can call into the hospital, speak to the emergency department and to the physician and say, I just want to give you an update about this client. And please don't change the meds. It's taken us like 6 months to get them right, So, we can do that. Caregivers want to need that. They want to feel supported with their decisions. And whatever those decisions are, they want to feel supported and they want us to be there for them in the case of emergency. So, it was nice to think that maybe some of those elements that families spoke about in the province that we actually as a company are striving to obtain. So, on that note, we provide a comprehensive care model to individuals in Ontario that are seeking support for their health journey. We want to minimize or eliminate the gaps. And we want to be basically outcome focused. So if we know that you can get better, you want to focus on really what those outcomes look like. Right place, right time. And I'm happy to take any questions, although I'm aware of the time. But I'm happy to stay on the call as necessary.
Okay, so if you stop sharing your screen, then Lynn, I will get the gallery view of everyone.
Thank you.
Thank you. That was very, very informative. We know where we can turn to in need of help. So we'll take some questions.
Okay, I see a number of hands.
I think we'll take the first one from Mr. Anil Sukhija, our chairperson.
Okay.
Please go ahead.
Thank you, Lynn. That was indeed very, very informative. There were so many other things that I would say even myself was not aware about the services you render. Thanks for letting us know. So my question is two-pronged. Number one is that you did mention somewhere that you can be reached at info@nursesonotwa.com, right?
Yes.
Who's sharing the screen? Please stop participating. No, okay. So my question is that is there a phone number that you can be reached? Because most of the seniors may not be comfortable going online and getting in touch with you. So if you can share a phone number, number one. And my second part of the question is, are your services, do you charge for your services?
Yeah.
Or is it free? And what is the setup? What is the cost, right? Yeah. When I say you charge means one part is your services or nurse on board services. And the other part is that you refer, say, for example, you refer for a blood work.
Yes.
Now, blood work is free, but if somebody comes at home, Dynacare or Life, they charge for coming home, right? That is to be paid. So
Yes.
how does it work in terms of charges, cost?
Yes. Thank you. Thank you for your questions, and those are excellent. And what I can do is certainly provide the number. I don't memorize it off by heart, but the number would be for a nurse on board. So, and that would go, and people could go in and leave a message. And Susan is very good. They go to Susan, and then she's the person then that then takes the information and determines sort of where it goes or whatnot. So yes, certainly by email, and I think actually that was her email, info@nurseonboard is the email, and then there's a phone number as well. Your second question about cost, yes, as a healthcare provider, so these are private services, and there's a lot of health services that some are partially covered by the government, like physiotherapy, but only 3 sessions, So if you think you need more physio, then you pay for them. So we'd like to think that at someday our services are of value and would be partially paid by the government. And certainly we've had some discussions with the former Lynn about that, and they recognized it, but right now it's not in the model, but hopefully it will be. So we charge like any other healthcare provider, like a physiotherapy, an occupational therapy and whatnot. So right now the rate is $100 an hour. And so our first, the history and social, the assessment, that first one is a one-time fee of $250. And it's usually a couple of hours that we go through, and then we populate that form into the health record, and then that provides an overall global perspective of the patient. So it would be something that any professional would do for sure. And then our services are charged $100 an hour, but in increments of 15 minutes. And so it might be where, okay, you have a brief phone call, well, that's fine. You're not going to charge maybe over that. But if I go out for a visit, then what would be the time that I actually spent in that visit? And for me, it's like, well, what time, for instance, like, okay, maybe there'd be other conversations or other things came up, but let's say I was doing a foot dressing or a certain procedure or whatnot. Well, then what was the time that I actually was there for that? Sometimes when we start, there's some the cost might be a little higher based on the amount of hours or time that we're collecting the information and dealing with the complexity of the information. And other times it's less. And it really is what the family want. So if they say, I'd like you to just do this and that's it, and we'll handle the rest. So it really depends on how much the family want to take on and deal with and know the system. Or maybe it's like, what, I don't have time, I'm working full time, I've got numerous things to look at, and I don't even know where to start. So can you just start handling that kind of situation? So that's part of that. And there's no HST on the fee, and we do encourage where, and again, this is where Sun Life can come in on certain services. Then we actually are able to fill in a nursing form and support what we do through Sun Life, and in some cases Sun Life pays then for those services to be done. So we try, and that's why we try so hard to work with different companies to get things back. And if there's a service out there that can be done in the public domain, well, then obviously that's what we would want for you. We want to get as much free healthcare support as possible. And your third question was, like, for instance, having blood work done in the home, things like that. You're absolutely right. And it might be, for instance, can they still go out? Is there somebody else to take them for the blood work? That's fine. Maybe there isn't anybody to take them for the blood work. And in that case, is it better that I take you for the blood work, and we wait in line? Or is it cheaper to have someone come in the home and do the blood work? So there's a variety of ways of which all of this can be sorted out. And so we have those conversations with the families so they truly understand, what they're up against. Yeah.
Okay. Thank you. That blood work was just an example of one service.
Okay. Yeah.
Yeah. Yeah. Thank you so much.
Okay. So next, Chandraji, go ahead. Bhavna, you're up next for the questions after Chandra.
Lynn, thank you very much for the excellent presentation. And as you said, many of the seniors, if they are, well, I say not poor, but in the marginal level, yes, will not be able to afford your services. And they may not have options open to them to do that. That's where I feel, the Ontario government did the home care and said, take care of yourself instead of staying in the hospital, but did not offer the seniors the modality to cover these expenses. They downloaded the expenses to the patient, but there's no way many seniors can afford you. I know somehow we have to make it, I know your company is working towards it, but it's not, $100 an hour may not be a amount that many can afford. And how can we help to get this in the forefront? Because all the baby boomers are going to become seniors, are already seniors, not going to. Sorry, that's a wrong choice of words.
Well, and I think that's where, I worked, as Sudash said, I worked at the Ottawa Hospital. I worked there for 37 years, and then I worked over at St. Vincent's. And, honestly, it was a bit of a shock working in the community to really see what's covered, what's not covered, and the incredible strength that families go through with trying to provide care to their loved ones. And I think, there's a new move towards like Ontario health teams and things like that. And I think the more the people in decision making, they truly understand what needs to happen. And, and is there a different model out there? We as a company are exploring developing a program of care for Parkinson's. But we know in the Netherlands, there's already the community support team of Parkinson's specialists go in and see the person. So, we've kind of, we're slowly moving to kind of putting more people at the source, but we still have a lot of work to do. And you're right, it's not, it's not for everybody. In terms of expense, and we totally get that. And I can honestly say, coming from where, I was salaried and that, and then all of a sudden you have to charge, it's tough. And in fact, I know Susan wouldn't like it, but I'm sure there's lots of times I just work for free, because you just see the need, you just do what you need to do. And, I'm not worried, but, you just try and do the best you can. And maybe just if you say, okay, well, like my budget is this is all I have. How can you help me the most? And then it might be, well, suggest here, go there, do this. And definitely we need to be speaking to our members of parliament, or the political people that really, have a voice further up the chain to be able to say, this is really what we need. And that's why I think with, the model of a nurse in the healthcare system, it's like, oh, we're always the ones at the bedside at the end of the day, everybody else leaves, but we're the ones there. And it's the same thing in the community. We're the ones that have the skill set to work with the others and then do the homework, right? So if the physio says do these exercises, well, then it would be nice to be able to download that, to myself and maybe the family or whatever, if we say, okay, this is what we need to do. But I mean, the families are taking on a huge amount of burden. And that's where, we can think about, well, is there some respite, or how can we help? Or we know that the Lynn also has a program of managed care, where if there's a lot of dollars being spent from the public coffers regarding sending people in, there's certain situations where they say, well, instead of us paying out the third party, we're just going to give the money to you, and you can manage, and getting help in, and you can manage the money. So that can be done in certain circumstances. But you're right, it's an issue, and I think it's and I think it's with anything. There's some people that have the ability or have the finance, and that's how they choose to spend the money. Some people, it's whatever, right? So you're right. You've made a really good statement. Thank you.
Thank you, Lynn. Next question from Bhavna. Bhavna के बाद आविन जी आपकी बारी और फिर इंदु जी.
Acha. Oh, thank you. It was very informative. My question is, I used to work in the nursing home and looking after the residents for almost 18 years. And I remember when you're in the day shift, within 1 hour, two people has to get 20 people ready. And that was almost impossible. And so they don't get enough care. And especially when they are old, it takes longer too. And some people are fussy, not fussy, but they want to wear certain dresses and all this, and it takes much longer. And some people need a 2 people transfer, so you have to get the lift and ask somebody to help you. And that's very time consuming. And the problem was, if you don't get them all ready within 1 hour, then the head runners come behind and say why they're not ready and all this. It was very stressful. So government normally give, I don't remember exactly, but they give per person, like per resident, you're supposed to get certain minute, but they hardly get even 5 minutes in the morning. And that's not fair to the resident, because they are paying the fee, and they are paying for the service, and they're not getting enough care. So, and they're always short staff on the weekend and Friday, people call in sick and all this. So they don't get enough care, and that's not fair to the people. So my question is, if a government should get more, the institute should get more staff, and they never get it because they're all in money-making business anyway. So is there any way they can have more staff and they can give some pressure on the institute, or government can help subsidize or give more money?
Well, you've hit the nail on the head, and for sure. And it's really, I think, when you think about, just because a person is at a certain address, it doesn't take away their health needs, right? So, and they're not staffed well, and there might be very little RN supervision. And like, really, they're the most vulnerable, and definitely COVID sure pointed that out. And so we really need to do a lot better work. One of the things that we do try to do is that we go in and we work with the retirement home, if they want to work with us, about making changes. And I have a colleague that's working with a patient, and this gentleman was falling 30 times a month. And she's gone in and working with some physio and helping him out. He now falls twice a month. Now that is dramatic. And yet, what can we help the PSWs work with? Is there a better way for them to maybe get him out of bed or do something like that? So we help to provide a bit of translation to the worker in terms of, well, maybe, we could do it this way. I also would like to think that, having some tough conversations with the people who run the place that, there is something called best practice out there. So, if they're not doing best practice, then that's not great. I mean, this summer I went into a very funky place, and there was no protocol for the diabetic in terms of when. So their blood sugar was in their food. They gave them some, rescue medication, but then, they didn't really. So there's guidelines out there that say best practice is this. And so who in those organizations are making sure that best practice exists within nursing, because I think nursing have their domain of practice. So, I just think that we keep trying to have these conversations, and there should be some oversight. And that's where, however Ontario was going to reward them on that there would be some oversight with that support, But definitely, it's so tough. I've learned so much from the PSWs for sure. Thank you.
Thank you. Oh, next question from Arvind ji. आपके बाद इंदु जी की बारी.
Thank you, Suresh ji. Lynn, after I listened to your presentation, I realized that it's such a huge field, and it's growing because the baby boomers are in their 70s and they'll need the services in vast numbers. You think that the organization or the health services are prepared to provide the service that we will need in less than 10 years, I think?
I'm not sure what the ultimate plan is, and I can honestly say I haven't had a chance to catch up on my reading with some of the Ontario reports. But I think it's a combination. I think people need to plan for their future and include financial plan for health. And often I've had to say, we plan for the rainy day, and gosh, it's starting to sprinkle outside. So we really need to think about our resources and how we want them used. And if health is important, then maybe a bit of the budget needs to be, started to think about of those things. And how much can the system bear? And then it sort of comes to taxes and how is that money coming out? It'd be nice to have a money making machine and, we could just, provide all those care. But I think we need to work smarter. And I think we need to, I find it difficult if, we need this person to come in and, they've already done the stuff. I've done the stuff. Like, why are we duplicating services? And, if we can streamline it for the patient and have a plan of care, like what really are we working on? So right now it's siloed. Nobody talks to each other. It's very episodic. You go in, you do the dressing, and you come back out. It's got to be more than that. It's got to be the comprehensiveness. I'd like to see, again, people have a family doctor. Maybe there's a family nurse role where you have certain clients that you check up on and, that you can provide that supportive care. I'd like to see that model in the healthcare system, but it's all we can do is help families, and even if it's small amounts of time, helping them direct where they need to go, what they need to do, what's really important. If I think that's sort of the best way.
Thank you.
I'm not sure if I've answered your question, but
Induji, are you there?
Thank you.
And you're mute.
Yeah, I've unmuted there. Thank you, Lynn. You presented a talk which makes us all think about it. Mm-hmm. And I think 3 weeks ago when I talked about it, I did say that in my culture, we always saved for the end, rainy days.
Yes.
What we had a false belief after coming or living here that the healthcare will be totally taken care by. I don't have to worry about it. I don't have to pay for it. And it's not only today. 40 years ago in the emergency department, if I had a fractured shoulder and I had to give a sling, patient had to pay for that.
Yes.
And nobody thought of it. Many times we didn't charge it because it was much more trouble charging $20 than writing it off. So the population is also under false impression that every service is paid. The second thing which we don't consider is our families are scattered everywhere.
Yes. Yeah.
Our son or daughter who's working, I'm just going to say in California, if has to leave job to come and take care, as become a caregiver and coordinator, will be very hard for them. And we won't want it either. So for them, if they can have a service which will help them coordinate, they may choose it. So we have to keep in focus. It's not just a senior who's going to make a decision. It is how it's comfortable for the family life also of the caregivers. And that's what we also have to look at it.
Yes. And I can say that, obviously people, they go in with maybe a trepidation. How is this going to cost, or this or that or the other? And often that we find is that where, they've seen us sort of take the lead, know what to do, make it happen. I remember I got a call I took the lady from for a geriatric assessment at the hospital, and they called back that afternoon and said, oh, we really want to admit her. And so I called the son, and he just said, Lynn, just do it. Just do it. And, because, he's working, he has this blended family, he's got a 5-year-old, his wife has cancer, like, how can you do all this, right? And so it's like, fine, no problem. So, I took her in, I got her admitted, I gave her the history with the nurse, I met with the team, I met with the doctor, we got everything organized, and then I went in periodically. I could call into the hospital in the evening, how's she doing? I could pop in and see her, everything's good. And then for discharge, I was able to take her home or take her back to the retirement home, and then work with the retirement home for the plan. And,
those kind of things, Lynn, are helpful. The last thing I want to say, because I have to go for another meeting, so I'm just going to pay. The power of attorney, which we give, the person, your power of attorney, if it is not available at the time of treatment, whosoever is next of kin can override all your wishes.
Yes.
So you have to be very careful how you have your power of attorney and who has it. The second thing is, just writing the power of attorney is not enough. You need to discuss it with your family that this is what I want to do. I got a call other day for no resuscitation power of attorney. The hospital followed it. And now the wife and the children said, we didn't understand what it meant. It was very painful for us to see our husband and father going through. What can we do? We want to sue the doctor for that. I said, and I talk to them every day. I said, yeah, I will sit down with you. I'll explain what it was. And so there is a very false, not understanding, or I wouldn't say false, but there's not clear understanding what these papers people sign means. So we need to look at it. And last thing, I'm going to tell you a story. I was raised with stories to give a message. We were building a back door, the patio at the back with the bricks. And my neighbors, the whole family puts the bricks on the patio, and father is doing, another are doing everything. And I'm doing it too. My husband is doing, and he says, you have to help me. So I did pick up the bricks for 20 minutes. I said, look, I'm going to go to the emergency and do a shift. and you get someone to put the bricks, because that's more important to me. I don't want to break my hand. I'm going to go to emergency and you do that. So sometimes we have to look at it, what is better for us as a family.
Yes, absolutely.
So I think it is the knowledge that the service is there. It is the knowledge it costs this service. It's the knowledge what you have given us is how it can minimize whether impact on us or an impact on other. But I will also say that the key thing which will help here is that you don't have to sit 8 and 10 hours in the emergency department without much information, which the other side will understand. And that's why we prepared a document called My Passport of Health, so that people can take it with them to minimize. So it is not service for everyone, but I think in your recipe book, you have to have this, that this is available. You can discuss it with your children. You can discuss it there. And then you can decide, is it cost versus ease of getting service? Is it the one for you?
Yes, exactly. Yeah.
So when Sudesh talked to me, I said, we need to let people know what is out there. Yes. Because I get called, how can I get this? And I'm trying to make my life a little bit easy too. Or where else I can go, what I can. So this kind of a service, I think I'm glad we recorded it. People can see it, and I will share with a couple of people I know who call me all the time this recording. So they can talk with their family who is in US, who is in India, who's there, that this is available. And then they can decide what is best for them as a family unit.
Yes, yes.
Thank you. Thank you very much. And I have to go, and thank you to all the seniors, and you will have lots of questions if we had another 2 hours.
Thank you very much for your wise comments.
Next, we'll take the question from Parveerji, Dr. Parveer Niogi.
Can you listen to me?
Anji.
I'll make 2 comments and then ask Lynn a question. Lynn, an excellent presentation. This is the document that Induji was talking about. It's called My Passport of Health, and it was prepared by her and is made freely available to any of our seniors who ask for it. I always carry mine around, particularly when I go to India. I know some people want to carry it on their mobile phones, but I trust a printed version much more. That's a generational thing. But I think it's extremely useful if somebody's taken into an ER. Yes. To have that document with them. My question is this: as you have pointed out and know, the demands of the people 65 and up on the medical system will only increase. Yes. There will never be enough money to satisfy all their needs. Is it worth making it known as to what services are available for free versus what services have a cost which are not covered by OHIP, and what services are available to enable seniors to live in their own homes rather than be shipped off to a retirement home? Because for the system as a whole, as you know, Lynn, it's much cheaper to keep a person in his house, his or her house, than to ship them off to a retirement home.
Yes, thank you very much. I really appreciate the Passport for Health. That's a great idea for sure, and excellent. And you're right, the needs sort of will exceed, and sort of where's the balance and where do people want to stay? And sometimes I think, well, you know, okay, if you go into a retirement home, it's going to cost so much dollars. And in some cases, they aren't assisted living, you know, they're just, you know, they provide the meals and provide this and a nice environment, and, you know, you can go down and, you know, do bingo or whatever. And if that's what you need and you think you want and you're surrounded by that, fine. But to put some people in the home, I mean, there may be, you have a good network of friends that come and visit, and really all you need is somebody to actually help you come in and for 4 hours, help you in the morning, help you prepare some food, and, you know, and then you can order some meals from Meals on Wheels or something.
Stuff like that.
So there's really many, many different options out there. and how to make it sort of the most effective. And when you compare the costs of this and that, I mean, you're right, it's like maybe $6,000 to spend in this. And so I think, well, gosh, that's a lot of money. But if I spend this in my own home, do I really, what do I really need? What do I really don't need? And where can I, maybe you need a sitter that comes in and can do things. You don't need a PSW per se.
That's right.
There's other lesser services. And part of it is in the workforce, people say, well, I only want to come to work for 4 hours. I don't want to just work for an hour. So it's very difficult to find those people. My gentleman that got ill, he was in a retirement home that offered no services. So, and he needed help with his medication because he'd made major errors. So I was able to find this RPN that came into this home, gave the meds 4 times a day and left. And, for that service, I don't know, it was $7 or something per visit or, whatever. And so we were able to negotiate and to find people out there that want it. So the whole PSW support industry is huge. I suspect it's going to get larger over these next few years based on the recognition of the PSWs and the supports that they need. But I think there's an avenue for other supports as well and to occur. And I think things like community center, like yourself, with this, the community outreach that you have is incredible. And there's something about, even if you live in a certain neighborhood, should we be thinking about in our neighborhood, let's get together and try and help people out, And so there's something called a Compassionate Ottawa right now that are looking at, be it helping people within their own homes. And so I think there's a lot of work that can be done, sort of volunteer, helping people out without it being costly, and I think we just need to sort of explore that. But some people really aren't lucky enough to have that.
I think the message there should be, you can't have a one-size-fits-all solution.
Yeah, for sure.
There is a bureaucratic system like OHIP, unfortunately, is built on a basic philosophy that there's set categories and set rules.
Yes, yeah. Right.
Talking about Compassionate Ottawa, I'm going to invite Chandra to ask her next question or comment.
Hi, Lynn, sorry, I'm trying to talk to you again. I'm one of the directors at Compassionate Ottawa. I work through ICC in that capacity.
Lovely.
And I really ask people to take the course on advanced care planning. What it does is how to start a conversation with your family.
Yes.
How to appoint a person who's going to stand with you in end of your life management. So, I gave this talk to the seniors. Some of them were there, most of them were there. But even when you go through, talk to people, that's a good organization, which is helping out people a lot.
Yes.
Because, we come from Indian background or East Indian background where we don't like to talk about death. We don't like to talk about end of life. But unfortunately, we are living in an era, we have to think about that. There's no choice for us. So that's, sorry, I had to say that because Compassionate Ottawa is trying to get everybody involved so that they can talk about this to the family.
Yes, that's good. I've been to a couple of sessions with Compassionate Ottawa. I believe Wendy Nicklin is part of the group.
Yes, all run by volunteers. There are 80 volunteers.
Yeah, and she used to be a director at the Ottawa Hospital. So yeah, for sure. It's an amazing society. And you're right, there's a lot of stuff out there that we can direct, people to. But that's awesome. I'm so glad to have met you.
Basanti, do you still have a question? I see you lowered your hand.
Yeah, Lynn, it was an excellent presentation today. You really enlightened all our colleagues with a lot of knowledge, what to think about, what are the facts of life, and any one of us in any circumstances would have to face one of these situations. As we know, the health crisis can come to anyone uninvited, unexpected, and it's going to be there. Hopefully we won't, none of us gets it, but it's inevitable. We would have to face it at one time or the other. The only thing is, you said you gave us a good information about what it involves as a cost-wise and everything else besides it. And one thing I would say, VON, or what you call NOB, nurse at your doorstep, would be a good concept which has been going on for 100 years now. And I think it is one of the very good basic steps to follow. And it gives our colleagues a thought of the day to think about what could happen. You know, this situation can come to any one of us. So I would think it was a very informative talk. And I think situation with the very kind of a multifaceted healthcare we need all the time now, especially in our age group now, that you never know what's going to happen tomorrow. So I think thank you very much. Yes, it was a very well discussed subject. And I thank you very much. And I think it would be informative to all of our colleagues here. Thank you.
Thank you so much. I really appreciate you saying that. It means a lot.
Thank you very much, Lynn. Thank you from all of us here.
Oh, well, thank you. It was a pleasure to be here today. And thank you so much again, Sudash, for allowing me the opportunity to present something that's always near and dear to my heart, patient care.
Thank you.
I'm just doing it in a different spot now.
And
thank you very much. And have a good day.
Thank you.
Okay.
One last word, Sudesh, with your permission. Lynn, when you are talking about long-term care and retirement homes and the subject of meals also came, you talked about meals on wheels. I would just like to let you know that our organization, ICCC, has started delivery of Indian meals through Meals on Wheels. So there are people in such care homes who actually want their ethnic meal or Indian meal. Yes. So this service is now available. For now, we have started the pilot project in West Ottawa, and our negotiations are going on with East and Centertown too. And within a month or two, we will start serving in the entire city of Ottawa, Indian meals, whosoever wants it.
Oh.
So I thought I'll let you know this, just in case sometime you talk to some people and they want some Indian meals. So I thought I'll let you know.
So $10 per meal.
Gee, I hope that includes me. I love Indian food.
you too can get on the list. It's in your area. It's being served in.
Well, and you have such an impressive website, and you know, I think there's always lots to learn from each other. And so, you know, looking at what you're doing and how you're reaching out, I mean, it's I'm certainly going to with Sudash's help, I'll certainly stay connected and go on and you know, certainly keep you in mind for sure. It's very impressive. Thank you so much.
So, Lynn, before you go, I will introduce you to our president, ICCC president, Mr. Kanwal Talwar.
Okay.
Unmute.
Thank you, Sudeshi. And thank you, Lynn, for a very good presentation. ICCC tries to provide variety of information to its members there. Our volunteers, it's a volunteer organization. We work very hard, Indu-ji, Anil-ji, Sudesh, all the others from the community, you know, all of the people present here. So the Meals on Wheels has been, you know, one service we started. Compassionate Ottawa, we have been active and we are very active from it on the beginning there, when it started there. And I would request again everyone to, and I sent a message to Chandraji also, that we can organize a session on the Compassionate Ottawa also. Again, and people should attend the workshop, Advanced Care Planning, which does not cost much to anybody there. And then there are other services also, the legal, services, power of attorneys, and so on. So we continue to do these sessions there.
Excellent.
And also your presentation, Anilji knows it and Sudeshji knows it. These are recorded there and they will be posted on the website so that people have ongoing information on the website there.
Okay.
Wonderful. And thank you very much for coming, and thank you very much, Sudeshji and Anilji, for organizing this event.
You're welcome. Thank you.
Thank you.
Remove pen and remove pen. There. Oops. You. Gallery. Anji. So now Mr. Anil Sukhija has a few bits of information to share.
You can stop recording now,
Okay.
Sudesh.